Good morning. So, I'm Dr. Prabitha. I'm going to present a challenging case of spontaneous closure of full thickness macular hole with posterior uveitis in a case of sarcoidosis. So, coming to the disease, sarcoidosis is a multisystem disorder characterized by the presence of non-caseating granulomas in various organs. This disease characteristically presents with reticular opacities in the lungs and bilateral hilar lymphadenopathy. The prevalence of ocular involvement in systemic sarcoidosis ranges from 12 to 76%, with ocular involvement being the presenting symptom in 30 to 40%. The most common being uveitis and conjunctival nodules. So, ocular inflammatory diseases can cause sight loss by macular involvement. Cystoid macular edema is the principal sight-threatening complication in uveitis patients. And macular hole is a rare complication following posterior segment inflammation and is rarely reported. So, a 60-year-old lady presented to us with chief complaints of pain and redness of both eyes on and off since 2 years. She was treated elsewhere and was on prednisolone 1% and atropine 1% eye drops. She had a history of low backache and shoulder pain on and off since 3 years. She had a history of dry cough since 6 months, and she was a known case of hypertension. So on examination, the visual acuity in her right eye was 6 by 6 and in her left eye was 6 by 36, which was not improving. And intraocular pressure was normal in both the eyes. Coming to the anterior segment findings in the right, anterior segment and posterior segment findings in the right eye. So there were few pigments in the cornea, traces of cells and flare. Posterior synechiae was present. There were pigments on the lens capsule. And fundus showed normal cup disc ratio with disc hyperemia and vitreous cells. There was vitreous haze and cells. In the left eye, there were fine keratic precipitates in the cornea. Cells and flare were seen. Posterior synechiae was present, and there was fundus. Fundus findings were inferior vitreous cells, and a punched out lesion was seen in the macula, and there was vitreous haze and cells. The findings were more in the left eye as compared to that with the right eye. So on systemic evaluation, the patient was found to have erythematous plaques and paniculitis like lesions on the shin, and Mantox was negative. Serum ACE level was 59, it was elevated. CT thorax showed subpleural lymph nodes, mediastinal lymphadenopathy, and mosaic attenuation due to small airway disease, suggestive of small airway disease. So the case was referred to immunologist, and a thorough workup was done and was diagnosed to be sarcoidosis. So topically, the patient was treated with prednisolone 1% eye drops 8 times a day with weekly tapering, and hometropin 2% eye drops twice a day. And systemically, the patient was given prednisolone 40 mg once daily with tapering, and tablet mycophenolate mofetil 500 mg once a day. And visual acuity was recorded, and OCT was performed in the first visit and subsequent visits. So this was a OCT finding. At presentation, in the left eye, you can see that vision was 6 by 36. There was a macular hole clearly seen in the OCT, and after 6 months, we can see that the macular hole has closed. So the occurrence of macular hole linked to posterior uveitis is an uncommon but possibly underestimated cause of sight loss. Etiological treatment seems to lead to macular hole closure in most such cases, and OCT is a very useful tool for assessing the evolution of these cases. So on literature search, we found that there are 3 articles which describe the formation of macular hole following posterior segment inflammation, and this was the duration of closure. So there was only one case which was previously diagnosed, which was reported by Nicholas Bonin et al. So which had sarcoidosis, treated with oral steroids, and it closed in 3 months. So in our case, an elderly female patient presented to us with panuveitis with full thickness macular hole, and on systemic evaluation was diagnosed with sarcoidosis. Following treatment with steroids and systemic immunosuppressive therapy, there was control of systemic paniculitis and reversal of systemic changes with reduction of inflammation and spontaneous closure of full thickness macular hole with improvement in visual acuity. Thank you.
Very nice presentation, Pratibha. Images were really good. Did you consider surgery at around 3 months or something like that?
No, ma'am. In the serial OCTs, we found that the macular hole was actually resolving. So we waited for it to resolve. That's why we did not think about surgery.
Inflammation had subsided by
Inflammation
then.
was subsiding, ma'am. Yes, ma'am.
Thank you. Nice presentation, Dr. Prabitha. This case highlights that all the cases of macular hole does not need, we should not
Yes.
jump to surgery immediately. They have nicely managed, and congratulations.
Thank you, sir.